Welcome back to the Blue Theatre, everyone. My name is Ghali Al-Ali from the Office of Development Affairs, and I have the pleasure of introducing you to our next session on keeping antibiotics working with behavioral insights. Before we start our session, we have a short video which has kindly been provided by the World Health Organization's Task Force on Antimicrobial Resistance Survivors.
AMR changed my life in every single way possible. I want my experience to open people's eyes and empower them to help prevent AMR. When I was 25, I had a car accident in Johannesburg, and although I suffered severe injuries to most of my body, the most severe were to my face. This basically followed into a 10-year facial reconstruction. In my 6th year, after having various prosthetics implanted into my face, I had pus seeping out of my face, and they readmitted me because they said to me it was an infection. Every single day, waking up to a recurring infection was frightening because I kept looking in the mirror, seeing this infection eating away at my skin on my face and thinking, am I going to have a face in the morning? How much further damage is it going to do? And I just didn't know what was going on. So they were prescribing the same type of antibiotic over and over and over again. And I said to myself, why is this infection so special? When my plastic surgeon decided to remove the facial prosthetic where he thought the infection was coming from, he sent it off for testing. And for the first time I saw something at the top of the test that read MRSA. And when I got onto the internet and started reading about what MRSA was, up came antibiotic resistance. And this really frightened me because it was the first time that I read about what antibiotic resistance was. When I finally, after 11 months, got this piece of paper in front of me that said there's 15 antibiotics listed on this diagnostic test and 5 of them would work for you. Why was it a guessing game? It shouldn't have been a guessing game. You know, I never thought this would happen to me, the same way that I never thought a car accident would happen to me. One of the most important things that I learned from having AMR was that I needed to be taking antibiotics correctly. You know, we often think antibiotics can cure anything, but I realized that they really should only be prescribed for certain conditions. The other really important message that I got from having AMR was to keep my hands clean all the time. This is a preventative measure that helps us prevent AMR in the first place. AMR can happen to anyone, and your life can change just like mine did in a split second. You are a key stakeholder to help preserve these life-saving medicines.
We would like to thank the Task Force and the World Health Organization for giving us permission to show this video. Now, I would like to introduce the chair of this session, Dr. Michael Hallsworth. Dr. Michael, welcome to the stage.
Thank you, everyone. Imagine a world where your life is threatened by a simple scratch, where routine surgery is no longer routine because the threat of infection is always present. And that's what happens today in places where antibiotics aren't available, and it will also happen if antibiotics stop working. And that scenario is not a dystopian fiction. It is the future that we face if we don't act on antimicrobial resistance. You can see antimicrobial resistance as a crisis in slow motion. Ineffective antibiotics are already projected to claim 40 million lives in the next 15 years, which would make AMR a bigger killer than cancer. Beyond the human cost, the economic cost is staggering. By 2030, AMR could inflict up to $34 trillion in annual GDP losses globally. And if you think this is an abstract problem, you may not have to wait long until it isn't for you. I had surgery on my kidney last year and developed an infection that was resistant to antibiotics. You keep trying the next antibiotic. You hope the next one works. If it doesn't, you begin to realize you run out of road. And that's the future we may face. I was lucky. Other people won't be lucky in the future. This is a real problem that we need to act on before it becomes a specific problem for all of us. We do not and should not wait until a century of medical progress has been undone. And the time to act on this silent pandemic, if you like, is now. And behavioral science is part of the solution. The World Health Organization calls behavioral insights a high-impact intervention, potentially even a game changer in tackling AMR. To explain how, I am delighted to introduce our distinguished speakers and panelists. We will start with a presentation from Dr. Najiba Abdulrazzaq, the co-chair of the UAE National AMR Committee, followed by Rasha Attar, the director of the Behavioral Science Group. Please join me in welcoming our speakers to the stage.
Assalamu alaikum. Thank you for inviting me to this event and thank you for the introduction. Today I'm really excited to showcase the study that was done by the Behavioral Science Group in UAE. And based on our interviews with patients and doctors, as you've heard from Michael about the AMR, how it's taking over the world and soon will be not having any antibiotics that works to treat simple infections. So based on our interviews, we found that the key driver of antibiotic resistance is perhaps inappropriate use of antibiotic. And from that point of view, the most pressing, accelerating for this resistance is perhaps the overprescription by physicians. And when we talk about that, we allude to the patients requesting many times antibiotics when we feel it is not appropriate. Because the patients, when they see themselves or their children are sick, they feel like they need an immediate treatment. Everything is fast nowadays, so they want to be better now and now only. And they don't want to miss work, they don't want their kids to miss school, so they really force the physicians to write antibiotics even when it's not required and the infection is perhaps a virus that will not be affected at all by the antibiotics. So this insisting of these patients is forcing many doctors to write even when they think it's not an appropriate prescription. And we all know in such a world we want patient satisfaction, customer satisfaction. So we wanted to test different behavioral interventions that would reduce patients' demands for antibiotics when an antibiotic prescription is obviously not appropriate. So we began by looking at self-reporting antibiotic use by our UAE residents. And we looked across all the Emirates and we found that 78% of the respondents, surprising to me, stated that they'd taken antibiotic in the past year. I have not taken antibiotic for perhaps over 10 years, just to keep it in perspective. However, this value was really similar to other countries that was surveyed by the Behavioral Science Group, which included UK, India, Indonesia, Kenya, and Nigeria, and also comparable to the WHO figures. So these figures really reflect perhaps the combination of the misuse of antibiotic and perhaps being unaware and uneducated about what antibiotics are and how do they really work properly. And that's why we took over to see how we can really look at behavioral changes into the patient's attitude. So in UAE, we recruited 4,251 residents for an online survey, and each participant were told to imagine that they had an infection, so fever, blocked nose, a sore throat, a cough, and then they watched a short video of a doctor repeating their symptoms and informing them that their consultation is about to begin. And these group of people were then divided into 5 groups. There was the control, so no change to the current practice, and then 4 other groups with behavioral interventions. And if we go through these 4 groups, so the first group, as I said, was just participants were told that they're likely to have a viral infection and that antibiotics will not work and probably they need home remedies. And then the second group was a delayed appointment. So the participants were offered not the antibiotic, but they were told if you're not feeling well, you can come back with another appointment. And then the third group, or shall I say the second interventional group, was alternative prescriptions. So these were offered an alternative to antibiotics, so like paracetamol, perhaps ibuprofen, some vitamins, and some lozenges to maybe clear the throat. The third intervention group was AMR education. So these group of people were told about AMR and how dangerous it is and the grave impact of antimicrobial resistance globally. The fourth group was the collective action, and these are the participants that they were told that UAE is working on reducing antimicrobial resistance, and being part of this group initiative, they should not take the antibiotic if it's not required. So we looked at the different response of these groups to each initiative, and surprisingly to all of us, or perhaps to me as a physician, I'm sure not to the behavioral audience, that all 4 nudges actually significantly reduce the patient's request for an antibiotic. So without any intervention, 31% of these participants asked for an antibiotic. The largest drop came from the group where they had alternative prescriptions given. So that was about only 20% of them asking for antibiotic. Perhaps they felt that they were looked after and that their symptoms were looked at and given importance, and that's why a prescription was written to alleviate their symptoms. Also, the other 2 groups with the AMR education and the collective action showed a 24% request of antibiotic, which is a significant reduction from the non-intervention group. And perhaps we have some social responsibility that we feel we ought to participate in, and that was perhaps the driver. Even the other group where delayed appointment was given did show some reduction in the request for antibiotic, but perhaps less because maybe due to inconvenience of a second opinion perhaps. So 26% of them only requested for an antibiotic during that consultation. So if we look at the big picture, we're really delighted to see how small behavioral nudges and proving the concept that small changes to the way we deal with our patient, the instruction that we give, and the interaction that we have with the patient have really a great impact. And these are really practical solutions and very low impact that can perhaps be adopted in any facility so that we reduce the unnecessary use of antimicrobials or antibiotics so that we keep antibiotics hopefully working for the future. There was the study that was done in UAE, and I'll hand over to Ms. Rasha to go over this study on a wider scale. Thank you.
Thank you, Dr. Najiba. Welcome, everyone. Welcome to this session. Welcome to BX 2025. As a director of the Behavioral Science Group, it is a pleasure to host this iteration of the now famous Behavioral Exchange. Welcome. Alongside our online UAE online experiment, we also conducted a larger international survey across 6 countries, capturing public awareness, understanding, and attitudes towards AMR. The sample perfect, thank you. The sample included over 10,000 participants across the UAE, India, Indonesia, Nigeria, Kenya, and the UK. These countries were selected to capture a range of income levels, regions, and healthcare systems across the 3 continents. In terms of existing attitudes towards AMR, almost 50% of participants ranked AMR in the top 3 most important priorities across all 6 countries. This was compared to other global issues like cancer, crime, pandemics, and epidemics. About 15% of participants across all 6 countries selected AMR as the most important priority in their country compared to the same list of problems. This suggests that AMR is seen as one of the key societal problems the 6 countries surveyed. This slide shows how limited public understanding of antimicrobial resistance really is. We tested participants' understanding of AMR by asking to identify from a selection of options which illnesses can be treated using antibiotics, the correct definition of antimicrobial resistance, and the causes of AMR. Comprehension was highest in the UK and lowest in Indonesia and India, where participants roughly answered about 40% of the questions correctly. It's likely that these figures are more than just low awareness. They also hint at linguistic and conceptual barriers. The term antibiotic doesn't always translate cleanly across different languages or health systems. For example, in some settings, antibiotic can serve as a catch-all phrase for any medicine, be it a fever remedy, antimalarials, even disinfectants, so blurring its precise clinical definition. To better understand this, future trials will test the impact of simply providing a clear definition of antibiotics before asking comprehension questions. This will help us isolate how much of the misunderstanding stems from language and framing versus actual knowledge gaps. As you can see from this slide, respondents primarily put the responsibility for preventing AMR on doctors. Almost 90% of the sample thought doctors were very responsible for preventing AMR. And this plot shows the average of all the countries combined, but finding that doctors were most responsible was actually true in each of the individual countries as well. Almost 3 in 4 people thought that individuals are also responsible for antibiotic overuse. Responses were generally consistent across the 6 countries. Now, while this finding gives strong legitimacy to doctor and patient interventions to reduce AMR, it also suggests that public awareness of the role of farmers in reducing AMR, such as giving antibiotics to their livestock, is less well understood across these 6 countries. I am very excited to take these learnings from our very early work forward to test proposed solutions further and to implement the most promising in the real world. You will hear more about these next steps in the panel discussion that's shortly about to start. Thank you, everyone.
Rasha, thank you so much for this presentation. And now I'd like to welcome our panelists to the stage. First of all, Francis Meyo, the Chief Executive Officer of Busara, an applied behavioral science organization headquartered in Kenya. Welcome, Francis.
Thank you, Michael.
Please, officer.
Thanks.
And also I'd like to welcome Farrah Alshash, who's the Director of Corporate Social Responsibility at PureHealth here in the UAE. So thank you everybody for being here today on this crucial issue. I'd like to start with you, Dr. Najiba. Your presentation showed promising indications that behavioral interventions could help reduce patient demand for unnecessary antibiotics in the UAE. So I'm really interested, what are the next steps for building on these insights and maybe turning them into practice?
Yes, these are really promising insights as was shown by this study, and we're really very thankful for such a study to show even our leadership how just small nudges can influence it. But yes, we are going to, inshallah, to take this into practice. We're going to pilot it in one of the facilities to see how these nudges will help us in curbing the demand, at least for antimicrobials, and hopefully looking at it whether it is actually reducing the prescription for antimicrobials, and also looking for the patient's satisfaction. Of course, this will also require a lot of education and for the healthcare worker on how to really address the patient's concern in a way that they leave satisfied without asking for antimicrobials, and perhaps not going to the next clinic asking for antibiotic, which can happen.
So you may be, supporting physicians to have these different conversations with patients. How much do you think there is direct patient pressure, or more just the feeling by doctors that the patient is expecting something? Sometimes research has suggested that doctors overestimate the demand from patients and almost proactively service it. Have you seen any evidence of this in your own work?
Yes, definitely. There's evidence of that, and it always comes whether we're talking about a governmental facility or a private facility. So private would tend to more look for patient satisfaction and the return of patients, whereas the government would probably be less towards that. But not only that, if we look at the physician's background, where they're coming from, as we know, UAE is multicultural, and the background is very different, so that the physicians themselves have a different perception in providing perhaps something that they feel not required, but maybe might be demanded by the patient. But I sit in a clinic and I still see patients. We do see patients that come and barge for antibiotic, and if you really give them the time, which is sometimes not freely available for many physicians, if you explain to them properly, then they are happy just to not take the antibiotic if it's not required. It's just that we feel, a lot of physicians feel nowadays they're very constrained for time, so that does not even help, and it's easier to give it, and I need to see my next patient. So that demand is also there.
Which leads me to my final question. How supportive are physicians of these interventions, do you think? They maybe know the purpose, but day to day it's more difficult?
I think looking at from the physician perspective, it's something that we really welcome. However, you need to really have a two-way conversation, so that the patients should also anticipate that I will not give them unless it's required, and that some of them would think that maybe it's AMR. What is AMR? And then you really need to go and explain to them. So I think the public still needs a lot of education. I think the survey also showed that we're not probably very well educated, and we do try in the ministry to do the education. However, the changing population in UAE is very challenging, so you need to keep educating, and we are looking at the moment also to introducing such ideas into the schools and universities, and we've already have a proposal in Ministry of Health to be discussed with the Ministry of Education to see how the concept of AMR and better antibiotic use and infection control, which is part of whole reducing AMR, into the curriculum of the schools and perhaps the undergraduate universities as well.
Yes, it's a classic collective action problem.
Yes.
We all lose in the end, but for individuals, it may be the best option to try and at least get a safeguard. I'll get the antibiotic and maybe I use it, maybe I don't. So that education point seems really crucial. And just thinking about education, Francis, I'd like to turn to you. Two of the countries in this survey were from Africa. Population growth in Africa is going to outstrip the rest of the world. How can we use behavioral science to make sure that we protect the effectiveness of antibiotics, but also maintain access to life-saving medicines?
Great, thanks, Michael. That's a very important question, partly because as the population in Africa grows, so does our responsibility to ensure there is access to antibiotics, but safe access to antibiotics. So I think being able to balance the trade-offs between access and stewardship becomes very important. We've done some work in addition to supporting the 6-country study that was done together with partners like the Wellcome Trust, Maisha Meds, which is a digital health company, and we've seen gaps in systems that produce AMR-seeking producing behaviors. So for example, in rural areas where pharmacies may have stockouts, there are behaviors that emerge like hoarding antibiotics or trying to not give full dosages for antibiotics because you may have stockouts. Now, these are not irrational behaviors, right? But they are adaptations to gaps within the system. So for example, with Meyo Meds, what we did was to be able to design a dashboard that could then help track when stock outages would happen across several pharmacies. So on the supply side, you're trying to fix that as well. But I think AMR is not only a supply side issue, it's also a communication issue, in that even the word for antibiotics in a lot of our African languages does not exist fully. And people may think of them, as Rasha mentioned earlier, like malaria medication, fever medication. So before we try and understand or change people's behaviors, I think we need to understand it at that foundational level.
Absolutely. And what do you think are some good ways of communicating antimicrobial resistance? Because it can take some time to explain, and it can be, is the resistance in me, in my body? Is it somewhere out there in the virus? These are not easy things to talk through.
Yeah, for sure. I think being able to frame when we are prescribing antibiotics, perhaps with messaging like antibiotics may help you, to if you take antibiotics when you don't have to, they may actually harm you, right? So I think on the patient side, being able to do some of those messaging campaigns would be very helpful. On the provider side, I think, as Doctor was mentioning, perhaps some peer reference, right? Knowing at what level are you prescribing the antibiotics as well amongst your peers in various places may be very helpful as well.
And maybe we should acknowledge there are side effects to antibiotics which can be made more explicit. There's growing interest in the gut microbiome that can be effectively eliminated by some types of antibiotics. Maybe there are ways of making this more salient to people, that these are not just harm-free, that there's a trade-off.
Absolutely, and I think before it gets to the patient side or even the provider side, we have to work with the pharmaceutical industry so that by the time they're generating the next generation of antibiotics, we're able to co-develop some go-to-market strategies and messaging that will exactly address that.
Indeed, thank you so much. So I'd like to turn to Farrah. We saw the results from the R-line experiment show that people have strong expectations for antibiotics, but nudges could potentially reduce the pressure. I know that BSG and PureHealth are launching an intervention to tackle the issue both from the patient and provider side. Could you tell us a bit more about this intervention, please?
Yes, thank you very much. How many of us know somebody who has said, oh, I got a flu, let me take some antibiotics in case? Or, been prescribed antibiotics for a course of 7 days and they thought after the 3rd day they feel great and they stopped taking the antibiotics. So these are all, just patient behavior, community behaviors that do relate to AMR. And as we've learned from all the studies that we've seen, that it does have quite a significant impact on life, longevity. And at PureHealth, we do have a very large ecosystem. So we're a perfect test bed to kind of work on this together with the behavior science group. We are doing the first ever here in the UAE double nudge, which we are actually tackling this 2 ways, by nudging the physicians as well as nudging the patients. So from clinical to community. And by nudging the physicians, we're kind of bringing out that responsibility down from the top down, kind of putting that on the physicians, whether we look into clinical flows or different nudges in the system, but also taking it a step further. And as even Dr. Najiba was saying, is that, the education to the patients. So that health literacy, making sure that education is there, is available, that people do understand. If the physician does not, for example, have time, sometimes I do understand the time constraint, but maybe making that messaging aware and easily accessible, whether it be in consultation rooms or waiting rooms or some kind of a digital behavior. And we are going to be rolling this out within selected PureHealth facilities, SEHA clinics to be exact. And hopefully, just depending on the outcomes, and we can look into, taking it on a national level. We are aligning with the national agenda. There's some great work that's being happened already. So this is just our part, basically, of kind of doing what we feel responsible to do. It is a personal thing for PureHealth. Our North Star, our vision is longevity. So, and as we know that AMR does affect longevity, we can see that there are a lot of health-related deaths because of this. And if we don't take action now, we will maybe go into a pre-antibiotic era, And that's a very scary thought. I think you were giving a story earlier. I was hearing about a personal experience. I've also had a personal experience with someone that was very dear to me, and it is scary to know that, you could have a surgery, you've been given antibiotics, and you think you're not going to get an infection, and then suddenly you get worse, and then you don't know why, and you find out that you are resistant. So just, I think the big chunk of it is nudging those patients to do the work together with the physicians, actually. The more education that we give, and the more we really embed it into our mindset, that's how we will make the change.
And do you have a sense right now of how the patient experience will change, for example, in the intervention when you go to the hospital? What would be different?
I don't know if the patient experience will change. I just think that, they will instill a little bit of confidence in them on the subject. So they will still have to, go to doctors, of course. We will go check. But I'll give myself as an example. The other day a few weeks ago, I was ill and I wanted to make sure, I didn't want to prolong my illness. So before I wanted to make sure, do I need antibiotics or not? So as a patient who is aware of the subject, went to the doctor myself. I did do the doctor thing, and then I asked for certain tests just to make sure I don't have an infection and it's viral. I was aware of all these things. So, and then the doctor as well took that initiative. So that double, I guess you say that double awareness and that double effort, it didn't affect the patient experience. And I think the more that people have that awareness, it will show also responsibility and trust. So I think that's the message that we want to give.
Thank you so much. And question to the panel. This seems like an issue where classically education is necessary but not sufficient, because we can know in theory that we shouldn't do something, but we also, as we know from behavioral science, have various ways of rationalizing our behavior. So do we need to think differently in terms of specific moments of decision, how to get those prompts into those moments rather than just being abstract? I know we need a greater sense of urgency here. Education will not be enough on its own. Do you have any sense of what could be done in that regard?
Yeah, sure. I think for the patient experience, you need to provide alternatives beyond the education bit. So, for example, in many African countries, I know folks are trying to develop low-cost diagnostic tools, right? So you can't just tell someone, do not abuse antibiotics, but you're not providing an alternative. So I think that will be an area where they will see a lot of growth. There's quite a lot of advancement happening with community health workers as well. So training them, yes, but then being able to provide perhaps some digital tools so that they can refer people to next level healthcare facility, for example. So I think being able to set out the infrastructures to support the education campaigns would be important.
Yes, also looking into what we do at the core is that personalized preventative medicine. So I think if we really focus, which what we do up here is focus on that personalized preventative medicine, we can kind of actually just prevent the whole illness to begin with. And I think that is also kind of the drive that we're also looking into and going through.
I do agree. Antimicrobial resistance got many pillars. So infection prevention, of course, if you don't have an infection, you don't use the antibiotics, so the abuse is less. And of course, the diagnostic is very helpful because many physicians would fear that what if they miss, so that still is there in the back of the mind of the physician. So having a diagnostic test that is really fast, which is available, however, they're still a little bit costly in UAE anyway. So if the manufacturers create something that is really perhaps more cost effective in addressing such issues, will perhaps add benefit, clearing the mind of the patient and the physician that yes, I am 100% sure that perhaps antibiotic is not required, so no need to take it from both mindsets. And yes, I agree that personalizing care, of course, is important, but yes, education is still. Despite facing all this, I have some patients who know I don't write antibiotics and really need it. Then they will go to the physician in my clinic and perhaps will ask, but other physicians know that this is my patient. So, so there is some in between us that we work together so that, if it's not required, please don't go ahead. But I think it's really important also to educate these, especially maybe for themselves, perhaps it's not a big issue, but when they see their child is really sick, I get a lot of phone calls from my relatives and they tell me, oh, the fever is there for 48 hours, I'm sure I need antibiotic. It's just the reassurance, and if they're not really medically oriented, sometimes they need that reassurance that it's going to be okay, nothing is wrong, just wait for an extra few, and then the next day they call you, yeah, you were right, we didn't do. So it's just still education is really an important part, I think.
But also understanding where people are coming from and how difficult that situation is.
Yeah.
How this is not an unreasonable request, it feels like. You mentioned people potentially going to elsewhere.
Yeah.
This perhaps points toward a coordinated response. Some work I did a decade ago was around social norm interventions for doctors who were prescribing more than their peers in the local area. And crucially, it was than your peers in your local area. It was harder to kind of excuse this away. So we also pointed out that you may want to talk to your colleagues because the data was collected at the practice level. So it was a prompt to say to your colleagues down the corridor, you're making us look less good because of this issue we spoke about. Do you think that a coordinated response is necessary for this collective action problem? Otherwise, people will just go to where they get antibiotics.
Yes, for sure, it's definitely required, and we have seen this pre-pandemic. There was a study that was done looking at different clinics prescribing a certain antibiotic that was overused from the surveillance that we were looking at. And we did target these physicians, and we did do for them education about stewardship and how to improve their prescription and show them their behavior compared to their colleagues. And that did really work in reducing the prescription of that clinic and specific doctors that were overprescribing. So yes, I think shame and blame is a good practice to do when people comply, especially when it's based, backed up with the scientific evidence. Yes, it's something really sure need to be worked on, and it's just in UAE the health system is a little bit complicated since we have different authorities, and looking into that sometimes become challenging, but we are working on that. The other thing I think is since antibiotic is in UAE is not given except by prescription, we do see a lot of people who come from their own country with a bag of antibiotics, so they don't even go to the physician, oh, it's a fever, let's take the antibiotic. I think that also is perhaps something that we need to look into.
The tragedy is that it is precisely because antibiotics are so powerful, almost magical, that people care so much about them and would take the bags around, if you like.
I don't think they are powerful if they're not required. So, most of the fevers will, even if you have a bacterial infection, like if you talk about a urinary tract infection, if you take the simple measures by drinking more fluid, taking perhaps, cranberry juice or something, your infection will clear up without requiring. If you have, gastroenteritis or something, and within 48 hours, even that bacteria will disappear. We've got an immune system that really is capable of getting rid of a lot of infections. However, of course, there are times that we do need these antibiotics to work, and unfortunately, it's a natural phenomenon that the bacteria will develop resistance. It's just the survival for the fittest. But our actions are accelerating this, so I think we should have the education about the importance of antibiotics, and that it's not an antiviral. So you have a virus, the antibiotic will not work. Antiviral are different, and then I think that simple education is also required.
Francis, do you think we're making progress? I mean, we've talked about all the difficulties. But at least there is the awareness that is changing. What do you think are the next steps?
Are we making progress? Tough question. I don't think so. And doctor seems to
we're perhaps, not as anticipated, perhaps. I mean, the very minimal progress. These bacteria, viruses, they're very clever. They're much more clever than our AI is able to catch up. But there is hope, I'm sure, if we do a collective action. I think it has to be everybody on board. And we now talk about One Health, so it's not just human health. We're also talking about going into animal, farming, agriculture, and even environment. So it's like a whole system that is really worsening the progress of our interventions, I suppose. But yeah, we now talk about the One Health, so everybody, every sector has to really participate from their point into tackling antimicrobial resistance, because it's a chain. So the food, the bacteria goes from food, from animal, from across all. It's not going to say, it's just going to go around.
Very true. I don't know what else I could add to that. I think as humans, we should try and be better. We can aspire to be better. We will try. There are definitely some points where we are failing, as you've said, but I think the awareness is growing. I would put my money on the next generation of antibiotics being developed and us making sure we don't mess that up, as we may have one more chance, right? So how do you elevate this issue to a patient safety issue even, so that authorities can really help step in and perhaps tighten regulation around it as well?
And perhaps more cost-effective diagnostic, rapid diagnostic, that will help, within an hour or so to give you the answer.
Yeah.
I think it's an overall program, isn't it? We look at antibiotic stewardship now, diagnostics, new development of antibiotics, and also patient and doctor prescriber behavior. But we are actually, we do know more than a decade ago on the behavioral side. We have seen that increasingly behavioral science can be part of that overall stewardship package that we can use, for example, social norm information, targeted interventions to make a difference. And that gives me some hope that we're bringing more elements together to make a difference to this issue, because it is one of the hardest ones to crack. Classic collective action problem. I really feel like we cannot give up here. Absolutely not.
We're not.
We're not giving up.
Never.
I invite any final thoughts from the panel on, priorities for the future. Where should we be looking in terms of human behavior and antibiotics?
Good, okay. I think, honestly, like with changing that behavior, so this is, the awareness is not just a clinical issue. This is what we all know that. And I think that Dr. Najiba gave a good example how it's through the whole food chain, actually, that it does affect the whole antibiotic use. So it is a public health challenge that does affect the longevity of communities. And I just think that as long as we really push towards that behavior change, because you can only implement so many things, but if the people aren't changing their mindset about it, it's hard to move, in that direction. So I think just constant education.
Well, Francis?
Yeah, for sure. I think the two concepts that I've kind of gathered today, the stewardship of AMR, kind of this discussion, and just access to antibiotics, because they're great. They help us, right? And I think being careful not to treat those as trade-offs, right? And seeing them part and parcel as a singular issue. I think that'll be a good pathway forward on this.
Well, thank you. I mean, bringing new technology together, investing in diagnostics, discovering new antibiotics, but crucially with that element of human behavior, that seems like the way forward to cracking this intractable but so crucial problem. And I'm glad to see the role of the UAE leading the way in this as well. So I wanted to thank the distinguished panel and our speaker for this panel, and I really hope it's given you some ideas about how we can think differently about antibiotics using behavioral science. Thank you, everybody.
Thank you. Thank you. Thank you.
Thank you, Michael.
Thank you so much to our presenters and panelists, and to Dr. Michael Hallsworth for chairing. Our last session in the Blue Hall here today will be looking at strengthening bonds across community, starting at 4:45 p.m. Hope to see you then. Thank you.